Good morning. I've got the NICE guideline, the fertility one, summarized for you to help with your revision of MRCOG exams. I hope you'll find this guideline summary useful, and if you do, then please don't forget to give it a thumbs up and also subscribe to my channel if you haven't already. So, the first pointer is to note that stress in male and or female can affect relationship and reduce libido, and also the frequency of intercourse, which contributes to fertility problems. So it's important to inform your patients about this. So more than 80% of patients will conceive within a year if the woman is aged less than 40 years and does not use any contraception, and also have regular sexual intercourse. Half of those who haven't conceived would go on to conceiving in the second year, and the cumulative pregnancy rate is over 90%. For more than 50% of patients who are under the age of 40 will conceive within 6 cycles of intrauterine insemination. About half of those who did not conceive in the first 6 cycles will conceive in the further 6 cycles, cumulative pregnancy rate of above 75%. So, artificial insemination, it's important to note that the fresh sperm is associated with higher conception than frozen thawed sperm. Female fertility and to lesser extent male fertility declines with age. Frequency and timing of intercourse, or artificial insemination. So, vaginal sexual intercourse is recommended every 2 to 3 days to optimize chances of pregnancy. For artificial insemination to conceive, insemination should be timed around the ovulation. So, alcohol, women should not drink more than 1 or 2 units of alcohol once or twice per week, and avoid episodes of intoxication as it reduces the risk of harming a developing fetus. For men, Department of Health recommends 3 to 4 units per day, which and if this is unlikely to affect semen quality. For men, excessive alcohol is detrimental to semen quality. Smoking, so women reduces their fertility. It's also important to note that passive smoking for women can also affect their chance of conceiving. For men, association between smoking and reduced semen quality exists, and it's important to inform your patient to and support them to stop smoking and to enroll them with a smoking cessation program. Caffeine, there's no association between consumption of caffeinated beverages and fertility problems. Obesity, women who are equal to or more than BMI of 30 take longer to conceive. Women who are obese and are equal to or above BMI 30 and are not ovulating, it's important to inform them that losing weight alone can increase their chances of conception. Men who are above BMI of 30 or equal to 30 are also likely to have reduced fertility. Low body weight, so BMI less than 19, and irregular menstruation or not menstruating, increasing body weight can help improve chances of conception. So tight underwear. So for men, there's an association between elevated scrotal temperature and reduced semen quality. Occupations, certain occupations can expose patients to hazards which can both reduce male and female fertility. Um, Over-the-counter drugs and recreational drug use can also interfere with male and female fertility. Complementary therapy, the effectiveness of this has not been properly evaluated. Folic acid supplementation should be advised to anybody who is trying for a pregnancy to start 400 micrograms before as soon as they start planning for pregnancy, and continue until 12 weeks of pregnancy, and to take a higher dose of folic acid, which is 5 milligrams if they are on anti-epileptic medication or are diabetic or have had a previous baby with neural tube defects. So women who have not conceived after 1 year of unprotected sexual intercourse in the absence of any known cause of infertility should be offered further clinical assessment and investigation along with their partner. Artificial insemination to conceive um, either with partner or donor sperm should be offered. Further, again, clinical assessment and investigation if not conceived after 6 cycles of treatment in the absence of any known cause of infertility. Whether using partner sperm, the referral for clinical assessment and investigation should include their partner as well. Offer an earlier referral for a specialist consultation to discuss options for attempting conception, further assessment and appropriate treatment where the woman is aged over 36 years, there is known clinical cause of infertility or a history of predisposing factors for infertility. Where treatment is planned that may result in infertility, such as treatment for cancer, early fertility referral is advised and should be offered. People who have chronic viral infections like hepatitis B, C, HIV should be referred to specialist centers so the relevant expertise and facilities can be offered to reduce the risk of in risk reduction in terms of passing it on and so forth. The semen analysis, the World Health Organization reference values are semen volume of 1.5 mils or more, pH of 7.2 or more, sperm concentration of 15 million spermatozoa per mil or more, total sperm number of 39 million spermatozoa per ejaculate or more, total motility, so percentage of progressive motility and non-progressive motility, 40% or more motile or 32% or more with progressive motility, vitality, 58% or more live spermatozoa, sperm morphology, percentage of normal sperms, 4% or more. First semen analysis, if it's abnormal, then a repeat should be carried out. Repeat should ideally be done 3 months after to allow time for cycle of spermatozoa to form and then to test it. However, if there's any gross abnormalities like azoospermia or severe oligospermia, then repeat as soon as possible. Ovarian reserve testing, so women's age as use that as an initial predictor for overall chance of success through natural conception or IVF. Use one of the following measures to predict likely ovarian response. So total antral follicle count of less than or equal to 4 for a low response and greater than 16 for a high response. AMH of less than or equal to 5.4 for a low response and greater than or equal to 25 for a high response. FSH greater than 8.9 for a low response and less than 4 for a high response. Regularity of menstrual cycles. Serum progesterone should be done in the mid-luteal phase, that is day 21 of a 28-day cycle to confirm ovulation even if regular menstrual cycles. Prolonged irregular menstrual cycles offer blood test to measure serum progesterone. So for example, if it's a 35-day cycle, then it should be done on the 28th day and repeated weekly thereafter until next menstrual cycle, because if they've got irregular periods, it's difficult to determine the exact ovulation period. So you have to repeat that test every week until the next menstrual cycle starts to check if they're ovulating. So prolactin measurement, it's basically only offered to patients who have ovulatory disorders, galacturia, or a pituitary tumor. Thyroid function test is only offered to patients who have symptoms of thyroid disease. Endometrial biopsy not offered to evaluate luteal phase. Investigations of suspected tubal and uterine abnormalities. If the patient does not have any comorbidities like PID, that's pelvic inflammatory disease, previous ectopic pregnancy, or endometriosis, offer HSG to screen for tubal occlusion because this is reliable test for ruling out tubal occlusion and is less invasive and makes more efficient use of resources. Screening for tubal occlusion using hysterosalpingo contrast ultrasonography is effective alternative to hysterosalpingography for women who are who are not known to have comorbidities. Women who do have comorbidities offer laparoscopy and dye tests, so tubal and pelvic pathology can all be assessed at the same time. Not offered hysteroscopy as part of initial investigation unless clinically indicated. Testing for viral infections, so testing for HIV, hepatitis B and C should be carried out. If positive, then offer referral to specialist advice and counselling and clinical management. If the man is HIV positive, fertility management discussions between couple, fertility specialists and HIV specialists all should take place. If the man is HIV positive, the risk of HIV transmission to female partner is negligible through unprotected sexual intercourse when all of the following criteria are met. So the man is compliant with highly active antiretroviral therapy. Man has a plasma viral load of less than 50 copies per mil for more than 6 months. There are no other infections present, and unprotected intercourse is limited to the time of ovulation. Advise couples that if all the criteria in the above are met, sperm washing may not further reduce the risk of infection and may reduce the likelihood of pregnancy. Man is HIV positive and is not compliant with their treatment, or the plasma viral load is not 50 mils and is actually greater, then offer sperm washing. Sperm washing reduces but does not eliminate the risk of HIV transmission. If couples who meet all the criteria in the recommendation above still perceive an unacceptable risk of HIV transmission, after discussion with their HIV specialist, consider sperm washing. Inform couples that there is insufficient evidence to recommend that HIV negative women use pre-exposure prophylaxis when all the criteria above that we mentioned have been met. For partners with hepatitis B, offer vaccination before fertility treatment, not offer sperm washing. Fertility treatment for women with hepatitis B. For couples where the man has hepatitis C, decision about fertility management should be the result of discussion between the couple, fertility specialist, and hepatitis specialist. Advise couple who want to conceive and where the man has hepatitis C that the risk of transmission through unprotected sexual intercourse is thought to be low. Man with hepatitis C should have discussions with treatment options to eradicate the hepatitis C with their appropriate specialist before conceiving. Susceptibility to rubella should be tested for, so all women should have it tested for their rubella status and offered vaccination. Women who are susceptible to rubella should be offered vaccination, advised not to become pregnant for at least 1 month following vaccination. Cervical screening program to avoid delay in fertility treatment. A specific inquiry about the timing and the result of the most recent cervical smear test should be made. Cervical screening should be offered in accordance with the National Cervical Screening Program guidance. Screening for chlamydia, so patients who are having uterine instrumentation should be screened for chlamydia trachomatis. If chlamydia is positive, women and their sexual partners should be referred for appropriate management, treatment, and contact tracing. Use prophylactic antibiotics before uterine instrumentation if screening has not been carried out. So, medical and surgical management of male factor fertility problems. Medical management is men with hypogonadotrophic hypogonadism offer gonadotropin drugs because these are effective in improving fertility. Men with idiopathic semen abnormalities should not be offered anti-estrogens, gonadotropins, androgens, bromocriptine, or kinin enhancing drugs because they have not been shown to be effective. Men should be informed that the significance of anti-sperm antibodies is unclear and the effectiveness of systemic steroids is uncertain. Men with leukocytes in their semen should not be offered antibiotic treatment unless there is an identified infection because there's no evidence that this improves pregnancy rates. Surgical management, men with obstructive azoospermia should be offered surgical correction of the epididymal blockage because it's likely to restore patency of the duct and improve fertility. Surgical correction should be considered as an alternative to surgical sperm recovery and IVF. Men should not be offered surgery for varicocele as a form of fertility treatment because it does not improve pregnancy rates. Management of ejaculatory failure. So, treatment of ejaculation can restore fertility without the need for invasive methods of sperm retrieval or the use of assisted reproduction techniques. However, further evaluation of different options is needed. Classification of ovulatory disorders. So the WHO classifies ovulation disorders into three groups, group 1, 2, and 3. One is hypothalamic pituitary failure. So you've got hypothalamic amenorrhea or hypogonadotrophic hypogonadism. Group 2 is hypothalamic pituitary ovarian dysfunction, predominantly polycystic ovarian syndrome. Group 3 is ovarian failure. So WHO group 1 ovulation disorders, are anovulatory infertility, improved chance of regular ovulation, conception, and uncomplicated pregnancy by increasing their body weight if they have a BMI of less than 19 and or moderating exercise level if they undertake high levels of exercise. Of women with WHO group 1 ovulation disorders, pulsatile administration of gonadotrophin releasing hormone or gonadotrophins with luteinizing hormone activity to induce ovulation. Group 2 ovulation disorders, so again, they're anovulatory, who have a BMI of 30 or more. Advise them to lose weight that may restore in ovulation, improve response to ovulation drugs, and have positive impact on pregnancy outcomes. So you can consider treatment with clomiphene citrate or metformin or a combination of both. When taking clomiphene, it's important to offer ultrasound during at least the first cycle of treatment to ensure that they are taking the dose that minimizes the risk of multiple pregnancy. Taking clomiphene citrate do not continue treatment for longer than 6 months. Metformin, inform them about side effects like nausea, vomiting, and other gastrointestinal side effects. In women who are resistant to treatment to clomiphene citrate, then you can either offer them laparoscopic ovarian drilling or combine treatment with clomiphene and metformin or gonadotrophins. Polycystic ovarian syndrome that's been treated with gonadotrophin should not be offered treatment with gonadotrophin releasing hormone agonists concomitantly because it does not improve pregnancy rate and is associated with increased risk of ovarian hyperstimulation. Adjuvant growth hormone treatment with gonadotrophin releasing hormone agonist and or a human menopausal gonadotrophin during ovulation induction in women with polycystic ovary do not respond to clomiphene. It is not recommended because it does not improve outcome. Effectiveness of pulsatile gonadotrophin releasing hormone with clomiphene citrate resistant polycystic ovarian syndrome is uncertain and therefore not recommended. Hyperprolactinemic amenorrhea, so dopamine agonists of women with ovulatory disorders due to hyperprolactinemia should be offered treatment with dopamine agonists like bromocriptine. Consideration should be given for the safety for use in pregnancy and minimizing cost when prescribing. Monitoring ovulation induction during gonadotrophin therapy. Ovulation induction with gonadotrophins inform that about the risk of multiple pregnancy and ovarian hyperstimulation before starting treatment. Ovarian ultrasound monitoring to measure follicular size and number should be an integral part of gonadotrophin therapy to reduce risk of multiple pregnancy and ovarian hyperstimulation. Tubal and uterine surgery. So tubal microsurgery and laparoscopic tubal surgery. So women with mild tubal disease, tubal surgery may be effective than no treatment. In centers where appropriate expertise is available, it may be considered as a treatment option. Tubal catheterization or cannulation. For women with proximal tubal obstruction, selective salpingiography plus tubal catheterization or hysteroscopic tubal cannulation may be treatment options because these treatments do improve the chance of pregnancy. Surgery for hydrosalpinx before IVF treatment. Women with hydrosalpinx should be offered salpingectomy, preferred by laparoscopy before IVF treatment because this improves the chance of a live birth. Uterine surgery for women with amenorrhea who are found to have an intrauterine adhesion should be offered hysteroscopic adhesiolysis because this is likely to restore menstruation and improve the chance of pregnancy. Unexplained infertility. So women who do not, so ovarian stimulation for unexplained infertility, do not offer ovarian stimulation to women with unexplained infertility. Inform women with unexplained infertility that clomiphene as a standalone treatment does not increase the chance of pregnancy. Unexplained infertility who are having regular unprotected sexual intercourse for a total of 2 years before IVF should be referred, and it should be referred and will be considered. Offer IVF treatment with unexplained infertility who have not conceived after 2 years of regular unprotected sexual intercourse. Intrauterine insemination. Consider unstimulated intrauterine insemination as treatment option in the following groups as an alternative to vaginal sexual intercourse. People who are unable to or find it very difficult to have intercourse because of a clinically diagnosed physical disability or psychosexual problem, or are using partner or donor sperm. People with conditions that require specific consideration in relation to methods of conception, so after sperm washing where the man is HIV positive, people in same-sex relationships who have not conceived after 6 cycles of donor or sperm insemination despite evidence of normal ovulation, tubal patency, and semen analysis. Offer a further 6 cycles of unstimulated intrauterine insemination before IVF is considered. For people with unexplained infertility, mild endometriosis, or mild male factor infertility who are having regular unprotected sexual intercourse, do not routinely offer intrauterine insemination either with or without ovarian stimulation. Advise them to try to conceive for a total of 2 years before IVF will be considered. Prediction of IVF depends on several factors like female age, chance of a live birth following IVF treatment fall with rising female age, number of previous treatment cycles. Inform people that the overall chance of a live birth following IVF treatment falls as the number of unsuccessful cycle increases. Previous pregnancy history. People should be informed that IVF treatment is more effective in women who have had previously been pregnant and or had a live birth. BMI. Women should be informed that the female BMI should ideally be in the range of 19 to 30 before commencing assisted reproduction, and that a female BMI outside this range is likely to reduce the success of assisted reproductive procedures. Lifestyle factors. People should be informed that the consumption of more than 1 unit of alcohol per day reduces the effectiveness of assisted reproductive procedures, including IVF. People should be informed that maternal and paternal smoking can adversely affect the success rates of assisted reproduction procedures, including IVF. People should also be informed that maternal caffeine consumption has adverse effects on the success rates of assisted reproduction procedures, including IVF. So criteria for referral for IVF. When considering IVF as a treatment option for people with fertility problems, discuss the risks and benefits according to the Human Fertilization and Embryology Authority, which is HEFA Code of Practice. Inform people that normally a full cycle of IVF treatment with or without intracytoplasmic sperm injection should comprise of 1 episode of ovarian stimulation and the transfer of the resultant fresh and frozen embryo. In women aged under 40 who have not conceived after 2 years of regular unprotected intercourse or 12 cycles of artificial insemination, offer 3 cycles of IVF with or without ICSI. If the woman reaches the age of 40 during treatment, complete the current full cycle and do not offer further full cycles. Women aged between 40 and 42 and are not conceived after 2 years of unprotected intercourse or 12 cycles of artificial insemination offer 1 full cycle of IVF with or without ICSI, provided the following 3 criteria are fulfilled. They've previously had IVF, no evidence of low ovarian reserve, where investigations show that there is no chance of pregnancy with expectant management, and where IVF is the only effective treatment, refer the women directly to a specialist team for IVF treatment. In women aged under 40, any previous IVF full cycle, whether self or NHS funded, should count towards a total of 3 cycles that should be offered by the NHS. Take into account the outcome of previous IVF treatment when assessing the likely effectiveness and safety of any further IVF treatment. Healthcare providers should define a cancellation IVF cycle as one where an egg collection procedure is not undertaken. However, cancelled cycles due to low ovarian reserve should be taken into account when considering suitability for further IVF treatment. So procedures used during IVF, so pre-treatment, if the patient's on oral contraceptive pill or progesterone-only pill, this does not affect their chance of pregnancy, of live birth. down regulation and other regimes to avoid premature LH surge in IVF, avoid premature LH surge in gonadotropin stimulated IVF treatment cycles, use either gonadotropin releasing hormone agonist down regulation or gonadotropin releasing hormone antagonist as part of the gonadotropin stimulated IVF treatment cycle. Only offer gonadotropin releasing hormone agonist to women who have a low risk of ovarian hyperstimulation syndrome. When using gonadotropin releasing hormone agonist as part of IVF, use a long down regulation protocol. Controlled ovarian stimulation in IVF. Use either urinary or recombinant gonadotropins for um, ovarian stimulation as part of IVF treatment. When using gonadotropins for ovarian stimulation IVF treatment, use individualized starting dose of follicle stimulating hormone based on factors that predict success, such as age, BMI, presence of polycystic ovaries, ovarian reserve. Do not use a dose of follicle stimulating hormone of more than 450 international units per day. Offer women ultrasound monitoring with or without estradiol levels for efficacy and safety throughout ovarian stimulation. Inform women that clomiphene citrate stimulated and gonadotropin stimulated IVF cycles have higher pregnancy rates per cycle than natural cycle IVF. Do not offer women natural cycle IVF treatment. Do not use growth hormone or DHEA as adjuvant treatment in IVF protocols. So, triggering ovulation in IVF of women with human chorionic gonadotropin to trigger ovulation in IVF treatment. Offer ultrasound monitoring of ovarian response as an integral part of IVF. Clinics providing ovarian stimulation with gonadotropin should have protocols in place of preventing, diagnosing, and managing ovarian hyperstimulation syndrome. Oocyte and sperm retrieval in IVF. Women undergoing transvaginal retrieval of oocytes should be offered conscious sedation because it's a safe and acceptable method of providing analgesia. The safe practice of administering sedative drugs published by the Academy of the Medical Royal College should be followed. Women who have developed at least 3 follicles before oocyte retrieval should not be offered follicle flushing because this procedure does not increase the number of oocyte retrieved or pregnancy rates and increases the duration of oocyte retrieval and associated pain. Surgical sperm recovery before ICSI may be performed using several different techniques depending on the pathology and wishes of the man. In all cases, facilities for cryopreservation or spermatozoa should be available. Assisted hatching is not recommended because it's not been shown to improve pregnancy rates. So embryo transfer strategies in IVF. Women undergoing IVF treatment should be offered ultrasound guided embryo transfer because it improves pregnancy rate. Replacement of embryos into a uterine cavity with an endometrium less than 5 millimeter thickness is unlikely to result in a pregnancy and is not recommended. Women should be informed that the bed rest of more than 20 minutes duration following embryo transfer does not improve outcome of IVF treatment. Evaluate embryo quality at both cleavage and blastocyst stages according to the Association of Clinical Embryologists and UK National External Quality Assessment Service for Reproductive Science Embryo and Blastocyst Grading Schema. When considering the number of fresh or frozen embryos to transfer in IVF, for women aged under 37, first full IVF cycle, use single embryo transfer. In the second full IVF cycle, use single embryo transfer if one or more top quality embryos are available. Consider using 2 if no top quality embryos available. Third full cycle, transfer no more than 2 embryos. For women aged between 37 and 39, in the first and second full cycle, use single embryo transfer if there are 1 or more top quality embryos. Consider double embryos transfer if there's no top quality embryo. In the third full IVF cycle, transfer no more than 2 embryos. Aged 40 to 42, consider double embryo transfer. IVF treatment with donor eggs use embryo transfer strategy based on the age of the donor. No more than 2 embryos should be transferred during 1 cycle of IVF treatment. Top quality blastocyst is available. Use single embryo transfer. Double embryo transfer advise people the risk of multiple pregnancy associated with this strategy. Offer cryopreservation to store any remaining good quality embryos after embryo transfer. Advise women who have regular ovulatory cycles that the likelihood of live birth after replacement of a frozen thawed embryo is similar for embryos replaced during natural cycles and hormone supplemented cycles. Luteal phase support after IVF. Offer women progesterone for luteal phase support after IVF. Do not routinely offer HCG for luteal phase support after IVF because it increases likelihood of ovarian hyperstimulation syndrome. Inform women undergoing IVF that the evidence does not support continuing any form of treatment for luteal phase support beyond 8 weeks. Gamete intrafallopian transfer and zygote intrafallopian transfer. There's insufficient evidence to recommend the use of gamete intrafallopian transfer or zygote intrafallopian transfer in preference to IVF in couples with unexplained fertility problems of male problems or male factor fertility problems. Indications for intracytoplasmic sperm injection, severe deficit in semen quality, obstructive azoospermia, non-obstructive azoospermia. In addition, treatment by ICSI should be considered for couples in whom a previous IVF treatment cycle has resulted in failed or very poor fertilization. Genetic issues and counseling. Before considering treatment by ICSI, people should undergo appropriate investigations both to establish diagnosis and to enable informed discussions about the implications of treatment. Before treatment by ICSI, consideration should be given to relevant genetic issues where a genetic specific defect is associated with male infertility, is known or suspected in couples, should be offered appropriate genetic counseling and testing. Where the indication for ICSI is severe deficit of semen quality or non-obstructive azoospermia, the man's karyotype should be established. Men undergoing karyotyping testing should be offered genetic counseling regarding genetic abnormalities. Testing for Y chromosome microdeletions, not routine investigation before ICSI. However, it's likely that a significant portion of male infertility results from abnormalities of genes on the Y chromosome involved in the regulation of spermatogenesis, and couples should be informed of this. Intracytoplasmic sperm injection versus IVF. Couples should be informed that ICSI improves fertilization rates compared to IVF alone. But once fertilization is achieved, the pregnancy rate is no better than IVF. Indications for donor insemination. So obstructive azoospermia, non-obstructive azoospermia, severe deficit in semen quality in couples who do not wish to undergo ICSI. Donor insemination should be considered in conditions such as high risk of transmitting a genetic disorder to offspring, high risk of transmitting infectious disease to offspring or women from man, and severe rhesus isoimmunization. Information and counseling. Offer information about ICSI and donor insemination to allow equal access to both treatment options. Couples should consider donor insemination, should be offered counseling independent from the treatment unit. And regarding all the physical and psychological implications of treatment. Screening of sperm donors. Units undertaking semen donor recruitment and the cryopreservation of donor spermatozoa for treatment purposes should follow the UK guideline for the medical and laboratory screening of sperm, egg, and embryo donors. Potential semen donors should be offered counseling independent of treatment unit regarding the implications for themselves and the genetic children, including any potential children resulting from the donated semen. Assessment to offer the women. So before donor insemination, confirm the woman is ovulating. Women with a history that suggests tubal damage should be offered tubal assessment before treatment. If there's no risk factors in history, offer tubal assessment after 3 cycles if treatment by donor insemination has not been successful. Intrauterine insemination versus intracervical insemination. Couples using donor sperm should be offered intrauterine insemination in preference to intracervical insemination because it improves pregnancy rates. Unstimulated versus stimulated donor insemination. Ovulating regularly, offer minimum of 6 cycles of donor insemination without ovarian stimulation to reduce risk of multiple pregnancy and its consequences. Indications for oocyte donations to premature ovarian failure, gonadal dysgenesis including Turner syndrome, bilateral oophorectomy, ovarian failure following chemotherapy or radiotherapy, certain cases of IVF treatment failure. Oocyte donations also considered when there's high risk of transmitting a genetic disorder to the offspring. Screening for oocyte donors, infectious and genetic diseases according to the UK guideline for the medical and laboratory screening of sperm, egg, and embryo donors, oocyte donation and egg sharing. Oocyte donors should be offered information regarding the potential risks of ovarian stimulation and oocyte collection. Oocyte recipients and donors should be offered counselling from someone who is independent of the treatment unit regarding the physical and the psychological implications of the treatment to themselves, to the genetic children, including any potential children resulting from the donated oocytes. Egg sharing scheme there should be counselling about particular implications. People with cancer who wish to preserve their fertility, so cryopreservation of semen, oocytes, and embryos when considering this before people start on chemotherapy or radiotherapy that's likely to affect their fertility. At diagnosis, the impact of cancer treatment on fertility should be discussed between the patient, between the person diagnosed with cancer and their cancer team. Following factors like diagnosis, treatment plan, expected outcomes of subsequent fertility treatment, prognosis of the cancer treatment, viability of stored and post-thawed material for cancer-related fertility preservation do not apply the eligibility criteria used for conventional infertility treatment. Long-term health outcomes of ovulation induction and ovarian stimulation. No direct association between treatments and invasive cancer, and no association of short to medium term between treatments and adverse outcomes, including cancer in children born from ovulation induction, and limit ovulation induction or ovarian stimulation agents to lowest effective doses and duration of use. Long-term health outcomes and safety for IVF. Absolute risks of long-term adverse outcomes of IVF treatment is actually low. The small increased risk of borderline ovarian tumors. Absolute risk of long-term adverse outcomes in children born as a result of IVF is low. Drugs for ovarian stimulation and IVF treatment should be used to its lowest effective dose and the duration of use. Well, that's it for now. So I hope you found this guideline summary useful. And if you did, then please do give this video a thumbs up and subscribe to my channel if you haven't already.